Okay, from today I'm going to start cornea and contact lens series. I think it will move. I don't know how many classes, maybe 50, 60 or whatever. So 50, 60 videos. So I think I should start from the cornea anatomy and physiology because it's directly correlated with the contact lens and all the pathologies, disease secondary to contact lens. And definitely I'm not an ophthalmologist, not an anatomist, or so I'll try to explain what within the limit of my knowledge. So let's discuss further. So slowly and slowly move to anatomy, then we will move to physiology, then we sometimes if there is something came that I think I should explain in relation to contact lens, I will explain. Okay, so let's move. This is the very first uh, video. So I'll make cornea, then I'll go to tear film, and then I'll go little bit about lead movement and how lead actually move, and I think that's it. And if time, I will go to I think to conjunctiva too. Yes, and then directly I'll move to contact lens. So first video in contact lens, I'll definitely make sure that it will be corneal physiology in relation to contact lens, and then slowly and slowly we'll move. Okay, so let's move further. So basically, introduction of cornea, it's a transparent avascular, not always avascular, but yes, central cornea is avascular, watch glass-like structure, interior one-sixth of the outer fibrous coat of the eyeball. I think it will come in MCQs. Interior, how much of area actually covered by uh, cornea? It's one-sixth of the outer coat. If all the outer coat is sclera and the cornea, this portion is one-sixth. Okay, fine. So let's move forward. So let's come to embryology. I have already told you that I'll try to explain as much as I can. Okay, so that's simple, not a very heavy thing. So I have to make it very beautiful. I am not thinking about it. Okay, so very simply that I'm going through it as an optometrist and I'm seeing it as a contact lens practitioner. So if there is anything that I'm like definitely going to explain in relation to contact lens too. Okay, so development of epithelium, as we know, 33 of days of gestation, triggered as the lens vesicle separates from the surface ectoderm, and definitely epithelium is developed by surface ectoderm. So two layers are superficial and the basal cells, and at 8 week of gestation and 26 week of gestation, all layers differentiate to basal cells, wing cells, and flattened cells, isn't it? So development of stroma. So basically, development of stroma, the basal layer of the epithelium cells secretes the collagen fibers and the aminoglycans, and it will make primary stroma. And primary stroma, mesenchymal cells migrate into the primary stroma. So what that secretes the keratocytes, and that secretes the type 1 collagen, which is very much what do you call it? So the secondary stroma basic component is type 1 collagen, isn't it? So that's happening 7th week of gestation. And then initially secondary stroma is rich of fibronectin and disappear as the mesenchymal cell appear. And Bowman's layer, remember Bowman's is not a membrane. Bowman's layer is start to develop from the 4th months of gestation and fully develop at the birth, isn't it? And let's move further. The development of endothelium. So at 6 weeks of gestation, mesenchymal cells extend beneath the corneal epithelium cells, and which create a primitive endothelium. And development of Descemet's membrane. At the 6 weeks of gestation, endothelium consists of the two layer of flattened cell, and endothelium cells of the central region cornea becomes a single layer and flattened the central region at 9th month of gestation, and then the rest of other interrupted basal lamella, and then that basal lamella becomes future Descemet's membrane, isn't it? So simple. So here's the picture of surface ectoderm, from which definitely epithelium, corneal epithelium is derived. Okay, you can see here, and from mesenchymal cells, these red dots, from there you can see the other structures actually uh, begin to form, isn't it? From the mesenchymal cells. So basically, from mesenchymal cells, you can see the secondary stroma is forming, endothelium is forming, and all these things. Okay, so it's not that all the cornea is formed by the single layer. It's not like that. Okay, So in this table I'm going to summarize it. The layer of the cornea in epithelium is developed from originally from surface ectoderm. It's clear, isn't it? So forms first stratified squamous and non-keratogenic epithelium. Okay, it's fine. So Bowman's layer, which is anterior limiting membrane, modified anterior stroma derived from neural crest. Basically it's not derived from anything, but it's just condensation of anterior stroma, isn't it? So acellular, yes, definitely Bowman's layer is acellular, not truly separated from embryonic layer, not truly separated from any other layer, and forms from the condensation of the stroma, isn't it? Okay. So stroma, which is another name, is substantia propria. So basically, neural crest mesenchyma is the main originating. So basically, migrating from the neural crest, and they are account for 90% of the corneal thickness, isn't it? Collagen lamella. 90% of corneal thickness is basically stroma. So what is descendant membrane, which is posterior limiting membrane? So descendant membrane secretes by the endothelium, isn't it? So neural crest derived is also from same thing, and thickens throughout the life. So basically descendant membrane. So what is final endothelium? Definitely again neural crest cells and single layer hexagonal cells responsible for the corneal detergents. So many of the students always find that what do you mean by detergents? So detergence is like something like relative dehydration state of the cornea, and many of the times students ask me what is relative dehydrated state. So it means simply that if you let the cornea be fully dehydrated, it will be hydrated more than 78%. It will be more than 70, but cornea remains at 78% approximately, isn't it? Because at 78% transparency is fully maintained. So to maintain the 78%, so main important role, yes, there is other five factors, but one of the great factors is endothelium pumping mechanism. So endothelium pumping mechanism means endothelium helps to put the water out from the cornea. So that's why for endothelium, single layer endothelium cell responsible for corneal detergence. Detergence means relative state of dehydration, basically. So I'll definitely going to talk about it later on. Okay, let's move further. So anatomy of the cornea. I think today we will stop in the anatomy of the cornea, and I'll make tomorrow, I think, the physiology of the cornea. So I think tomorrow or day after tomorrow. So dimensions. So dimensions, the anterior surface and the posterior surface. Anterior surface is elliptical, convex. See, this convex and this concave is very tricky. Posterior surface is negative power, negative almost 6 diopter. Anterior surface positive power, positive always 48 diopter. That's why it's convex and concave. Okay. To see from outer side, it's something like both look like convex. That's not the case. If you go to my optics video, you will understand why it is convex, because n is higher and here is n is low. So high index bulges out towards the lower index in here. So n double dash is low index bulges out towards the high index. That's why it's negative posterior surface. That's why it's positive. It's very important, this concept, and just I have to understand why anterior surface is convex, because higher index bulges out towards the air, and why posterior surface is negative, because lower index aqueous is bulges out toward the cornea. Okay. So average horizontal diameter is really always different in anterior posterior. In MCQs, these questions come. Okay, just understand. So average horizontal diameter is approximately 11.75, and average horizontal diameter of the posterior surface is smaller, approximately 11.5 mm. So average vertical diameter is approximately 11 mm. Just remember, these parameters are really good questions for the MCQs in your whatever exam. Okay, in Nepal it's definitely in a masters and what do you call license exam. Okay, and applied anatomy, I think it's important. Microcornea and megalocornea, it's very important in case of MCQs. So basically we say microcornea and megalocornea based on horizontal diameter, not based on vertical diameter. So it's always important horizontal diameter, because in contact lens definitely we always SVID, isn't it? Horizontal visible iris diameter. So horizontal diameter is always important. Okay. So in adult, if less than 10 mm the horizontal diameter, then it's we call microcornea. In adult, if less than greater than 13 mm, we will call it megalocornea. In birth 2 years, it's very different. So less than 9 mm, it's called microcornea. In birth 2 years, it's greater than 12 mm, it's called megalocornea. That's why you read your MCQ question very well. So if author specifies some age, then definitely MCQs answer is differ. So in MCQs, it's typical questions. So So in microcornea, hypermetropia, glaucoma, optic nerve hyperplasia is common association. In megalocornea, high myopia, astigmatism, but normal visual acuity is also associated with megalocornea. So this is the picture of microcornea. This is the picture of megalocornea. Okay, let's move further. Corneal thickness: central is thinner and peripheral is thicker. So central is thinner and peripheral is thicker. It's always happen in the minus lens, isn't it? If you ever catch the minus power of the spectacle lens, it's always like that. But even though our cornea is like the minus lens, but it acts as a positive lens. Why? Because the posterior surface is surrounded by the aqueous humor. It's very important. Okay, so applied anatomy of IOP estimation, basically corneal thickness, thicker the cornea, we overestimate the IOP, isn't it? So central corneal ulcer are more prone to perforate than the peripheral ulcer because of central cornea has minimum thickness. And there are a lot of things, but I just want to stick it to anatomy and let's move further. So corneal curvature is central 5 mm is optical zone, basically very important, and anterior curvature we take 7.8 as a anterior curvature radius because that's Goldstein, and posterior is 6.5 mm, flatter in the men than the woman. I don't know about it, but yes, if it is written, I think so, but I don't know. Refractive power anteriorly we consider minus plus 48, 88, 48 in posterior power. Approximately minus 6 would be better, but minus 5 it works. Net is 43 diopter, yes, and 43 diopter is two-thirds of the total power of the eye, yes. Refractive index of the cornea 1.376, that's very important. Refractive index taken in the what do you call that? Keratometry is 1.3376. Why? Because we measure only front surface of the cornea and we want to derive from the front surface of the cornea whole power of the cornea. So that's why we measure corneal curvature at the front surface, but at the same time we want the power of the cornea as a whole. That's why we want to minus the posterior surface in result. That's why we reduce refractive index consideration in case of corneal topography or in keratometry. So that's why that's the difference. Okay, in actual it's 1.376, but in keratometry we consider 1.3376, whatever, 75. Okay, so applied in keratoconus, what is keratoconus? I'm definitely going to talk about the keratoconus, the disease keratoconus, in one video, another video, but not like recently. But I'll definitely going to make it. So basically, name keratoconus, thinning and forward conical bulging of the cornea, irregular myopic astigmatism, which is definitely keratoglobus. What do you mean by that? That hemispherical protrusion of the whole cornea. In keratoconus, it's like a particular area, like this is whole cornea, then this particular area is thin. But in keratoglobus, it means that protrusion of whole cornea and generalized steepening and thinning. It's not like something at a focal point, but in keratoconus, it's definitely in the focal point. So with the rule of astigmatism is common, but keratoconus is not like that. Irregular astigmatism, and in pellucid marginal degeneration, as we call it, pellucid is a clear, isn't it? Pellucid means marginal means in margin, degeneration means a degenerative disease. So corneal thinning affected in anterior corneal 4 o'clock to 8 o'clock. It's not about anterior cornea; it's about cornea. So thinning of the cornea in around 4 to 8 o'clock. So if this is cornea, around from this to this, here is the thinning area, isn't it? So ectasia above the thinning, above thinning, and basically means ectasia over here, isn't it? Above the thinning. If this area is thin, ectasia is over there. So this against the rule astigmatism might be common, is that's very simple and it's commonly asked in the questions. Okay, MCQs. So which type of astigmatism you'll see in pellucid marginal degeneration? This is common question against the rule astigmatism. Corneal plana, which is flattening of the cornea, result of the high hypermetropia. But unfortunately, I have never seen corneal plana in my clinical experience. I think because I'm young, I don't know, but I have never seen corneal plana as a topography. Yeah, I have never seen, but yes, it is there. So corneal curvature is useful to determine astigmatism, fitting contact lenses, and IOL power measurement. Corneal curvature can be measured with keratometry ophthalmoscopy, handheld keratometry. Oh god, handheld keratoscopy is very devastating. Yes, definitely not at all. Yes, in camp setup, yes, we can think, but yes, not a good instrument. Yes, keratometry, corneal topography, yes, definitely. So main important point, fitting of the contact lens, we measure corneal curvature. Yes. So histologically, there are five we read. Obviously, Dua's layer is in question, but yes, it's stated somewhere. So enteroepithelium layer, which is from surface ectoderm, and anything from the surface ectoderm, definitely it's very active in metabolism. That's why enteroepithelium is highly active in metabolism, because it's it embryological origination. So this Bowman's layer, just remember it's layer, not a membrane. So central stroma, which is stroma substantia propria, this means membrane, and endothelium layer. Endothelium. Okay. So epithelium. Let's move further with this speed. Okay. Just dot. So stratified, squamous, non-keratinized. Just remember these three words. Just Google it. Understand these words. It's very important. Okay. So basically 50 to 90 micrometer thick and 10% of the corneal. Just remember, it's always important what is central thickness and the peripheral. Peripheral is thicker. Even epithelium is peripheral is thicker. Yes, definitely. Stroma, peripheral thicker. Epithelium is central, approximately take rough idea about 53 micrometer. Okay. So I have made one video in epithelium epithelium mapping. Just you can go there and watch. So 5 to 6 layer of nucleated cells. Definitely continue with the bulbar epithelium at the limbus, and hydrophobic in the nature. You just remember hydrophobic in the nature epithelium, but at the same time stroma is typically hydrophilic. That's very important. Hydrophobic nature of the epithelium and hydrophilic nature of the stroma. Even for the drug penetration, that's very important, because we prefer dual nature of the drug, not because hydrophobic nature of the epithelium is very important whenever penetration of the drug is considered, isn't it? So hydrophobic in nature and sets at the regular interval, replaced by growth of the basal cells, and entire epithelium is replaced in 6 to 8 days. That's very important whenever you are doing foreign body removal, or whenever you are doing anything. So you must understand that how much time it will take to actually regenerate entire epithelium. It will take approximately a week. So layers of the epithelium, we will definitely talk about the cells. So basal cells in the base, tall columnar polygonal cells arranged in the palisade-like manner. Just remember what is this sorts and on the basal membrane, oval nuclei and few organelles and germinating layer. Yes, that's important. Basal cell layer as a germinating layer. Okay. So basal cell layer formally attached to the basal cells and the anterior wing cells by desmosomes and macula occludens, and that's how transparency and barrier function of the epithelium. That's very important. Okay, so it basically attached to basal cells with wing cells with the desmosomes and macula occludens, and it helps with the transparency and barrier function of the corneal epithelium. So then definitely first basal cells, then wing cells, and then we'll move more anteriorly. Wing cells comprise 3 layers of polyhedral cells like wings, flattened nuclei, and lesser organelle than the basal cells. That's important. Now flattened cells and the topmost cells, isn't it? So consists of two most superficial layer flattened cells, long, thin, and flattened nuclei, numerous desmosomes, and macula occludens. So zonula occludens only present here. So in cornea, other layers, there is no zonula occludens. Is there in only present in the flattened cells? Sometimes MCQ yes, but I don't know. So entire cell wall of the most superficial cells has many microvilli and microplica. Isn't it very important for to hold the tear? So coated with the charged glycocalyx. I think you understand this stuff. Charged glycocalyx. So what actually it does? So allows the hydrophilic spread of the tear film with the blink. See, as I have already stated, epithelium is hydrophobic. Then how tear, which is actually water, is holding in front of the cornea? Because of the charged glycocalyx and because of the microvilli and microplica. So microvilli and microplica is coated with the charged glycocalyx, and that charged glycocalyx actually make cornea from hydrophobic to hydrophilic. Okay, but actually cornea is hydrophobic. Just remember this thing. Allow the hydrophilic spread tear with a blink. It's very important, that concept of uh, coating of charged glycocalyx in microvilli and microplica. So the basement membrane secreted by the basal cells and composed of collagen and glycoproteins and added with the basal cells via the hemidesmosomes is basement membrane of the epithelium, and posteriorly bends indistinctively with the Bowman's layer. It's not membrane, it's layer, Bowman's layer, and becomes thick with age, and it's seen in diabetic case. Or the diabetic case, it's thicker. An abnormal basal lamella leads to recurrent erosion and epithelial defect. That's very, very, very bad disease. Recurrent epithelial defect. It's very, very painful disease. So basically, I'm talking about this. This is basically microvilli, this structure, villi, and glycocalyx coating. Can you see dot 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 dot, dot glycocalyx, and in which tear film is attached. So that's what I'm. So basal cell, it secretes basically basal lamella too, and so basal a little bit. A middle cell is wing cell, and obviously it's superficial cells. Just remember this. This is long basal cell columnar cells, and then wing cells, and superficially it's superficial cells. Just remember this, that this is hemidesmosomes and this is desmosomes. So hemidesmosomes connect the columnar cell with the basal lamella, and desmosomes connects cells with each other in lateral fashion. So applied anatomy of epithelium is a healthy epithelium surface repels dyes such as fluorescein and rose bengal due to the tight junction complex, isn't it? So and then glycocalyx maintain the tear film stability is very important. And basal hemidesmosome system prevent the detachment of multi-layer epithelium sheet from the cornea, and abnormality result in recurrent corneal erosion also. So basically, see, if there is severe case of hypoxia and long-term hypoxia secondary to contact lens, then they in that particular case this hemidesmosome systems basically works very poorly, and then a sheet of cornea, a corneal epithelium is detached from the basal sorry from basal lamina, and these conditions are very poor conditions and very bad conditions, and they can cause it can cause by the cornea, especially contact lens, which is very, very less decavity, very less oxygen permeability contact lenses. So these are the cases. We'll definitely talk about these complications in our complications chapter, but yes, I want to tell you in applied anatomy too. So basically, corneal ulcer and epithelial corneal erosion picture is there. If in vitamin A deficiency, corneal epithelium becomes keratinized. Is very important. So basically, corneal epithelium is non-keratinized, isn't it? But vitamin A deficiency, corneal epithelium becomes keratinized. It's important. So so epithelial deposition of iron in keratoconus is called Fletcher-Ring. In keratoconus, yes, one of the sign is Fletcher-Ring. So what do you call Bowman's layer? Bowman's layer. It's important, not a membrane. It's a layer. So a cellular homogeneous zone thickness is roughly 8 to 14 mm. Sometimes asked in the Viva too, and sometimes asked in MCQs. It's a very common question. And it binds to the stroma anteriorly with the basement membrane of epithelium posteriorly, and composed of condensed collagen fibers, not a true elastic membrane because there is no basement membrane, and condensed superficial part of the stroma is basically not a membrane. That's why we don't call Bowman's membrane, it's Bowman's layer. So condensed superficial part of the stroma, so basically that's a Bowman's layer, and resist to infection and injury, which is very, very important work of Bowman's layer, and once destroyed does not regenerate. That's why we have scars. That's a very important clinical correlation. So you will ask, people will ask, faculty will ask in your exam why there is a scar, what are the mechanisms. So you will definitely learn in the wound healing in the cornea, but remember that once Bowman's layer is destroyed, it doesn't regenerate, and the regeneration process stromal collagen fibers come, and there is loss of the transparency at the particular area. That is called scar, isn't it? So applied anatomy of layer is corneal wound and ulcers penetrate the Bowman's layer. New collagen fibers produce the irregular pattern. Obviously, regular pattern is very important for the transparency, and and after wound healing, leaving behind the opacities. So I think we know the type of opacities, isn't it? Nebular opacity, macular opacity, leukomatous opacity, and adherent leukoma. There are a lot of things. So nebula, term nebula, it itself mean the small what it clouds is, isn't it? Faint opacities. Scar involves superficial stroma along with the Bowman's membrane, interfere with the vision, and irregular astigmatism. I think it's interfere with the vision a lot because of anterior position and because of this scattering of light. So macular opacity, macula means The word itself called macula means what? Macula means a point, isn't it? A dot. It means a dot actually, literally. So scarring involve Bowman's layer and up to a little bit half of the stroma, but not that deep. But it's called. Can you see? It's clearly it's nebular opacity. So leukomatous opacity means the scarring involves the half, more than half of the stroma is called leukomatous opacity. Adrenal leukoma means whenever iris in penetrating injury, iris added to the cornea and whole cornea becomes uh, opaque. Whole cornea has opacity. So corneal facet is corneal surface depression at the site of healing. It's always there, isn't it? So keratactasia is corneal curvature is increased because of the opacities. It's always there in case of uh, opacity conditions. If there is a large scar, then there is definitely flat surface and there is definitely stiff surface. It's always like heel and the bottom. So stroma propria. What do you mean by stroma propria? Substantia propria is another name of the stroma. Sorry, stroma propria. Substantia propria is another name of the stroma. It's 0.5 mm thick at the center, 0.67 mm thick at the periphery, and approximately 90% of the total cornea. And there is sometimes it's asked questions which of this layer is the strongest layer. I don't know which of the layer is stronger. Definitely, I think it's stroma, isn't it? It's a thicker and the more weight is governed by this stroma, isn't it? So composed, yes, definitely resistance to the chemical. I think it's different layer, but strongest, yes, definitely is much. So composed of the collagen fibril, main the type 1 collagen. The ground substance is made by proteoglycans, and the nature of the proteoglycans is very important when you are going to talk about the corneal relative state of corneal dehydration. And definitely there is a cells which is keratocytes, cells, keratocornea site cells, keratocytes, isn't it? And then lamella. So what are the lamellas? That lamella is very important. What is lamella? Lamella means lamella is main structural strength there. Okay, so arranged mainly in 200 to 300 lamellas in the centrally. Peripherally is greater number. That's why periphery is larger. So 500 approximately peripherally parallel to each other and in corneal surface. These lamellas are continuous with the sclera uh, at the lamella means these lamellar fibers are continuous with the sclera. Yes, definitely in case of sclera they becomes larger and there is no regular fashion of arrangement, but in case cornea there is a regular fashion of arrangement, isn't it? So anterior one third is obliquely oriented. That's very important. Because of this, anterior one third is obliquely oriented. Anterior one third has it actually way stronger than posterior two third. The strength of the stroma is always lies in the anterior one third because of its orientation. It's very important. So it's very important whenever you talk about refractive surgery. Okay. So posterior two-third of the stroma alter alternating layer of the lamella at a right angle to each other. Okay, that's posterior two-third. But remember, anterior one-third are way stronger than posterior two-third. It's very stronger. So that's very important in case of refractive surgery. So X-ray diffraction study shows the parallel arrangement central lamella adopts the concentric configuration of at the limbus forming a weave. So predominant collagen fiber is always type 1. Just remember it very easy and very good question in your MCQs. Okay. So others are definitely 5, 6, and 11, 12, and 15. So these are the arrangements shown in this picture. This I think it's electron microscope. I don't know. So keratocytes, the cells of the cornea, occupy 2.5 to 5% in stromal volume. Just remember, long, thin, flattened cell running parallel to the corneal surface is very important. Running parallel to the corneal surface with eccentric nucleus and long branching process. Just remember, this branching process are very long. Okay, responsible for the synthesis of stromal collagen. That's good point. And the proteoglycans during development and injury as well. Very important. Whenever there is an injury, so one of the good questions in first years of optometry, second years of optometry is corneal wound healing. And just remember the great importance of wound healing and the keratocytes and how they produce stromal collagen fibers, how they produce proteoglycans during that injury and the healing of the injury, which is very important. Obviously, they produce stromal collagen and proteoglycans during development and injury as well. So this is the picture. So anterior, this is how the so anterior epithelium is here, Bowman's layer is here, yes, and this lamella. This lamella keratocyte, they want to show this is keratocyte, how they are going, and see this is lamella over there. So this is just a picture I want to show you. So besides keratocytes, some other cells are also found in the corneal stroma, which are they are wandering macrophages, histiocytes, lymphocytes, and polymorphonuclear nucleocytes, which is very rare. It's very important. So now let's discuss about the what do you call it, the stroma, and then I think it's too much long video, then I will stop for the okay. So let's discuss about it. So details and the features. Stromal thickness is definitely 90% of all thickness of cornea. See, remember, collagen in dry weight of the cornea. If cornea we are taking dry weight, then 70% of the stromal content is collagen. Just remember this point, okay? In collagen, type 1 is predominant, 80 to 85%, provide tensile strength and transparency. So remember, there will be question in your MCQs at that particular point. Remember, type 1 is the most predominant collagen fiber in stroma. Okay, other key minor is type 5th, second minor, which is 10 to 15%, and regular fiber diameter and spacing essential for the transmission. So both type 1 and type 5 are essential. And others collagen is type 4, what it is, interfibril connection and anchoring. And type 12 and 15, fiber organization. Type 3, low in the normal corneal stroma, increase whenever wound healing. It's very important. Type 3 is always increase when it's wound healing. Okay, so organization is collagen fiber arranged in regular orthogonal stacked lamella uniformly spaced, which is very important in corneal transparency. Isn't it the Morris theory? Yes, we will definitely talk about it in our next I think the next to next. So I'll talk about Decimon's membrane and the endothelium in next class. So I think it's too much long. So be stanchious.